Hello everyone, very happy good morning, and I hope each one of you is doing good. This is the last video in the series of the electrocardiogram or the ECG. This is the 22nd video or 22nd clip, and I have placed them together in the playlist under the name of the electrocardiogram slash ECG. The only purpose of making these videos was to give you guys a basic idea about the electrocardiogram, and I haven't gone into the much details of it because this is not important how much I know. This was important how much I should tell you so that you will start thinking about the ECG. Now in this clip, which we are to be given as a last clip, we will talk about certain very basic things about the ECG paper, what we are supposed to look at the ECG paper to start our sort of questioning the finding of the ECG paper, because these are the basics things. These are the one which we should always be very careful as a doctor. It may be related to patient's data. It may be related to the machine specific feature, which are known as the standard feature. So let's talk about it. And at the end of the video, please like the video, share the video, and also subscribe the channel. And do press the bell icon to get the latest videos, which obviously will be on different other topics in the coming videos. Thank you once more for watching the videos. So whenever you look at the ECG paper of any patient, you need to start it from the very basics information. For example, you should look at the name of the patient. You should look at the age and gender or sex of the patient. You should also look at the ID or the medical record number of the patient. For example, there can be two patients with the same name, and probably they may fall in the same age category, and they may belong to the same gender. So there will come the importance of the patient's and medical record number or the identification number which the hospital gives to every patient, and this is very specific number. You should also look at the date on which the ECG was done. This is very important because sometimes we are looking at the old ECGs and the patient has got a clinical picture which may be different from the previous ECG. So always look at the date at which the ECG was done. Or not only the date is important, but also the time at which the ECG was done, because in certain of the cases, for example in cardiac ischemia, the findings can change within minutes. The findings can change within hours of the ECG when the ECG was done. So always look at the time at which the ECG was done, because sometimes when a cardiac ischemia patient comes to the hospital or emergency department, we need to carry on the ECGs after every 15 to 20 minutes, and the finding, for example, if we had done the ECG at 1 p.m. then and we do the ECG again at 1:20 p.m. then there may be different changes. So always look at the time at which the ECG was done. So these things regarding the personal the patient's profile are very important to look at. This cannot be you should never forget this important point. Next point, which is very important when we look at the ECG paper, you should always try to find out this digit 25 millimeter per second. This is very important to look at the ECG paper and try to look for this digit. What is 25 millimeter per second? It is the standard ECG paper speed. This is the speed when you press the ECG machine button, start button, and the paper starts coming out of it. This is that speed at which this paper will come out of the machine. And what does 25 millimeter per second means? Let's see what is 25 millimeter. It simply means that if you start the ECG machine and you push the start button, and you also start your microsecond watch, then in 1 second 25 millimeter width of the ECG paper should come out of it. This is the standard ECG paper speed. Now 25 millimeter is because we know that width of one small box is 1 millimeter, and the width of one large box which contains 5 small boxes is 5 millimeter, and the width of 5 large boxes will be 5 into 5, 25 millimeter. So if there are 5 large boxes like this one, their width will be 25 millimeter. And we had also seen that the duration of one small box is 0.04 second, and the duration of one large box which contains 5 small boxes is 5 into 0.04, that is 0.20 second, and the duration of 5 such large boxes will be 5 into 0.20, that means 1 second. So when this is the standard speed of the ECG paper, that when it starts coming out of the machine in 1 second 5 large boxes should come out of it. Now there is a different options, like it can be 12.5 millimeter per second, it can be 50 millimeter per second, and if somehow someone alters the speed of the ECG paper, it will affect everything. You may take someone as a tachycardia, you may take someone as a bradycardia, but actually patient is not neither suffering from the tachy nor the bradycardia, but only someone has in ignorance or whatever you can say, by mistake, someone has changed the standard ECG paper speed. So this is very important to check. What will you check? 25 millimeter per second. It should be 25 millimeter per second rather than 12.5 or 50 millimeter per second. This is very important. Another thing which is important for you to note on the ECG paper is this mark. This is a sensitivity marking, and this reading 10 millimeter per millivolt. This is important that you note this thing. Why? Because that means this is the standard voltage which is being delivered to the machine, and that causes the height of the deflections both upward and downward. This is the sensitivity of the ECG machine. What does that mean? If you see this 10 millimeter per millivolt, it means that 1 millivoltage which is delivered to the machine should produce a height of 2 large boxes, because one small box is equal to 1 millimeter in height, and this one small box should be generated by a voltage of 0.1 millivolt, and this large box which has a height of 5 millimeter should be produced by a voltage of 0.5 millivolt of the current given to the machine. So in total, if the machine is being delivered 1 millivolt current, it should produce a height of 10 millimeter or 2 large boxes. So whenever you look at the ECG paper, try to look for two things. One, this marking, this is known as the sensitivity marking, and its height should be equal to 2 large boxes, that will be equal to 10 millimeter, and it should be written somewhere 10 millimeter per millivolt. That means a voltage of 1 millivolt being delivered to the machine will generate a height of 10 millimeter or 2 large boxes. So 0.1 millivolt equal to 1 millimeter or 1 small box, 0.5 millivolt will be equal to 5 small boxes or 1 large box, and 10 millimeter will be generated, or the height of deflection of the QRS complex will be 2 large boxes when the current is being delivered of 1 millivolt. What are the other options which can a person can put up by mistake or by choice? These may be the 5 millimeter per millivolt or 20 millimeter per millivolt. That means in case of the 20 millimeter per millivolt, a current of 1 millivolt which is being given to the machine will generate the QRS complexes of double the height of the standard voltage sensitivity. This will be around like 4 large boxes height marking. So this is very important to also note that the standard voltage of the machine should always be 10 millimeter per millivolt. So along with checking the patient name and other data, you need to check the standard speed of the ECG paper and also the standard voltage marking and written of the 10 millimeter per millivolt. This is very important finding. Another thing which should be noted on the ECG paper, that we had seen that correct placement of the limb leads is when you put the red on your right arm, yellow on your left arm, green on your left foot, and black on your right foot. This is the mnemonic goes, read your good books. So that will generate a totally negative or absolutely negative AVR, where P, QRS complex, and T will be negative. This is very important. But if you see an ECG paper where you see a positively deflected AVR, then it can be because of two reasons. Either the patient is dextrocardic. patient's heart is located towards the right side of the chest. So left ventricle will be on the right side rather than being on the left side. Or it can be the wrong placement of the limb leads. Someone has not followed this mnemonic, like putting the red on the right and yellow on the green, but someone has put the yellow on the right arm and red on the left arm. So it will generate a positively deflected AVR. So always look at the AVR, and it should be negatively deflected in every normal patient other than the dextrocardiac or abnormal placement of the limb leads. And the last thing which we need to check on the ECG paper is the correct placement of the chest leads. There is a phenomena which we call the normal progression of the R wave in the chest leads, where we see that in lead V1 and V2, the negative deflection is deeper than the positive deflection of the R wave. And in V3 and V4, especially in the V4, there will be the height of the R will be almost equal to the depth of the S wave. But as we move from V5 to V6, the wave of depolarization is going towards them, so they generate a tall R wave and a very small S wave. This is known as normal progression of the R wave, that as we move from V1, V2, V3, V4, V5 and V6, R waves keeps on becoming taller and taller, and S wave keeps on losing its depth. So it should normally happen, but obviously there are certain anomalies which cause this poor progression of the R wave, like old anterior wall MI. If there is no pathological cause, then it may, if this progression of the normal R wave is disturbed, for example, if there is a tallness of the R wave in V1, V2 and V3, and there is shallowing or a low height of the R wave in V5, V6, or if the R wave does not go high even in V5, V6 and V4, R is not as taller as you are seeing here. In this case, it will be known as loss of the progression of the R wave. It can be because of anterior wall MI, but if it is not the pathology, then you are to check the correct placement of the chest leads, because normally we had said that we need to place the chest leads very carefully. V1 in the fourth intercostal space in the right parasternal border, V2 on in the fourth intercostal space on the left side of the sternum, V4 in the fifth intercostal space in the mid clavicular line, and V3 in between V2 and V4. V5 and V6 both are placed in the fifth intercostal space, V5 in the anterior axillary line and V5 in the mid axillary line. So if we do not follow these lines and we somehow place the V5 and V6 in the place of V1 and V2, there will be a loss of progression of the R wave. So other than pathology, the normal progression of the R wave is needed to show the correct placement of the chest leads.